Okay, madam.
I am Tirupona Sundari and I am a MCGP 11th batch trainee. Good evening, everyone, and a very warm welcome to all of you. Thank you for joining us today for this CME program organized by the CPD Committee of the College of General Practitioners of Sri Lanka. Today's session is on a very important and timely topic. It's the management of acute malnutrition in children. This program is credited by the Education, Training and Research Unit of Ministry of Health and carries one CPD point. Before we begin, I would like to extend my sincere appreciation to all the general practitioners and medical officers who have taken the time to participate in the evening. It is now my pleasure to introduce our distinguished speaker for today, Dr. Manoji Gamage, Consultant Nutrition Physician, Nutrition Division, Ministry of Health. Dr. Manoji Gamage is a highly respected clinician and academic. She is a board certified in clinical nutrition and currently serves at Nutrition Division of the Ministry of Health, Castle Street Hospital for Women, and the National Institute of Nephrology, Dialysis and Transplant. She has also served as a consultant nutrition physician at the Lady Ridgeway Hospital and has undergone specialized training as a clinical fellow at Birmingham Children's Hospital and University Hospital Birmingham in the UK. Dr. Gamage has contributed significantly to national nutrition guidelines, authored book chapters including the nutrition chapter in the concise textbook of pediatrics, and has a strong research background in pediatric and renal nutrition. She is also a founding member of the Sri Lanka College of Nutrition Physicians and currently serves as the secretary of the Sri Lanka Medical Nutrition Association. We are truly privileged to have her with us today. Please join me in welcoming Dr. Manoji Gamage Madam to deliver the presentation. Madam, it's over to you.
Thank you very much, Siri, for that kind introduction. First of all, I would like to thank for giving me this opportunity to talk to this community of general practitioners, and I highly appreciate you joining today amidst the weather conditions and prevailing situation. Thank you very much for joining in also. So let me share my screen now. Can you see the screen, Siri?
Yes, madam.
Yes, madam. We can see. I can see now.
Right. So thank you. So I'll be talking about management of severe and moderate acute malnutrition in children. And you're free to put any questions that comes up while the program is going on. And I hope Thiri we will be having discussing the questions at the end. Is it Thiri?
Hello?
Are we discussing the questions at the end as well?
Yes, madam. There will be a question and answer session also.
Right. Okay. So so you can post your questions in the chat box. So at the end of my presentation, my objectives are that you will be able to understand the present stage of acute malnutrition in Sri Lanka, and also to know about the guidelines that are available for the management of acute malnutrition, and also the management of severe acute malnutrition in children and moderate acute malnutrition in children, and what are the long-term outcomes of acute malnutrition. So these are my objectives. So to start off, let's see what is acute malnutrition. So acute malnutrition is defined a state of malnutrition that is acutely happening. So to diagnose this, the tool that we use is the weight for height chart or weight for length chart for children who are less than 2 years. So in the Child Health Development Record, you have this chart. It's not the first that you see when you turn the book, but you have to turn it two more graphs, and you have this weight for height chart or weight for length chart for children. And severe acute malnutrition is when the weight for height is less than -3 st. And moderate acute malnutrition is when it is between -2 st to -3 st. So looking at the Sri Lankan's perspective at the moment, so I would like to show this. So this is from the Family Health Bureau Nutrition Month data. And we can see the 2024 data is here. That's the last that is updated. So you can see further. So the acute malnutrition, the severe acute malnutrition and moderate acute malnutrition. You can see that the severe acute malnutrition, there is an improvement in the last year. However, the moderate acute malnutrition has been quite stagnant over the past decade. And also you would see that stunting, which is up there. So stunting is the shortness of the children below 5 years. So that is also has been stagnant over the past decade. So this is some problem that we have encountered and we are looking into solving in respective to children malnutrition in our country. So the guidelines that are available to manage acute malnutrition. So this was the previous guideline published in 2019. And this is the latest from WHO, which was published in 2023. And so my talk will mostly be based on this guideline. So what is new about this guideline, which was published in 2023? You can see that sorry about that. So in the 2023 guidelines, you can see that the scope, they have increased the scope. So mostly the previous guideline, they only dealt with the severe acute malnutrition. But of course, this in the new guideline, they also address children below 6 months, and also mostly the prevention has been highlighted with regards to malnutrition in children below 5 years. So this is the important areas that has been touched in this new guideline. So talking about children who are less than 6 months, so the guideline is talking about at risk of poor growth and development. So that is because of the significance of this children cohort, because this time of growth is important, also important part of their overall growth as a human being. So when they talk about children who are at risk of poor growth and development, who are they? So they are the ones who are born with a baseline infants with poor growth based on sequential measures. So that is when you see somebody who is running in the red zone in the growth charts. So that is somebody that is in this category. And also if there are who are risk due to poor birth outcomes, like if they are they were born low birth weight, or if they are born IUGR. So those ones are at risk of poor growth and development. And also even a single measure of being low has to be taken into consideration, especially in this cohort less than 6 months. And also if they have known risk factors for poor growth and development, such as congenital heart disease and cerebral palsy. So this cohort is important and has to be shown special attention when we are practicing in pediatrics, because these groups are very vulnerable for malnutrition. So the other important factor that has to be emphasized is that throughout the guidelines in the world, previously, even the other guidelines, we have been concentrating on the child, concentrating on the baby only. So the most of it is about the management of the baby and how to look after, so on. But this new guideline emphasizes the importance of acknowledging and caring for the mother and the caregiver, both as an interdependent pair. So it's important to look after the mother also, and to see and to support the mother to look after the child. So that's an important thing, I think, moving forward in improving the health indicators of children below 5 years, even in our country. So it's important to know when you meet a child with severe malnutrition, not only to look at the child, but also to look at the mother to see whether she has a problem in taking care of this child. So I'll move on to this case scenario to stimulate your thoughts. So Sarah is a 1.5 years old child, baby girl, brought to your Well Baby Clinic by her mother for routine assessment. Mala, her mother, complains that she eats very little. And you detect that Sarah is faltering in growth with regards to the CHDR when you look at it. And you see that in her growth chart, she has recurrent episodes of faltering towards the red zone in the weight for height charts, weight for length chart. And in the background, Mala is a 19-year-old and Sarah is her first child. She lives with her husband, who is a manual laborer, and they struggle to survive as a family. So how are we going to intervene for the development of this 1.5 years old child? So let's look at the management of infants and children, 6 to 59 months with severe wasting and nutritional edema. And we'll discuss as we go, how we proceed with Sarah as well. So do we have to admit Sarah? So these are the indicators for admission, hospital admission with severe acute malnutrition. So first thing, so after seeing that the child is in the red zone for weight for length chart, then again, if you have these criteria, one or more integrated management, the danger signs, that is, the child is not taking breast milk or vomiting everything, or had convulsions or lethargic, unconscious, and even having active convulsions now, then of course, those are danger signs and that child has to be admitted. And also if there is severe edema, which is with regards to low albumin and nutritional edema, so that's an indication. And also if the child has very poor appetite. So that is, you give a test dose of a therapeutic feed, which I will talk you to in my next slides. So when you give that, and if the child fails to complete at least 80% of the given portion, so then you would say that there is poor appetite. And this is an indication for hospital admission. And this guideline specifically talks about a bit more actually. So more than that also, if the child has medical problems that do not need immediate inpatient care, but do need further examination, such as HIV, tuberculosis, or if they have things like pneumonia and diarrhea, dehydrated, so that kind of things, or severe anemia. So that kind of things, of course, then also failure to gain weight or improve clinically in outpatient care. And also if you see that previously also this child has been having several episodes of severe acute malnutrition, then you need to do an in-depth assessment. Even if they don't have acute problems, then you have to do an in-depth assessment to see whether this child needs an inpatient care. But however, you can also manage these children outpatient basis also. So even if their weight for height is in the red zone, but they have a good appetite and they pass the appetite test, and there is no immediate danger signs, as I told before, and there is no criteria needed for in-depth assessment, such as previously I mentioned in my slide. So then if you have no criteria as such also, then you can manage these children on an outpatient basis as well. So first I'll talk about inpatient management of children between 6 months to 59 months with severe acute malnutrition. So the management of inpatients in the hospital setting is described under 10 steps and also in major 3 areas. So those are the initial stabilizing phase, the transition phase, and a longer rehabilitation phase. So let's talk to see what these stages are. So the first initial stage is where you actually try to rescue the child out of the dangers of acute illness. So those are the things that you talk when there is hypoglycemia, hypothermia. So those are the life-threatening things: dehydration, infection, and electrolyte imbalances and micronutrient deficiencies. So those have to be corrected in the stabilizing phase at the beginning. As you can see, the stabilizing phase can move on to 1 to 7 days. So those have to give priority in this first stabilizing phase, that is to stabilize the child. And then you have to start cautious feeding together. In the stabilizing phase also, you start cautious feeding. And then cautious feeding, I will talk to you what is meant by cautious feeding. Cautious feeding is to gradually and slowly giving food. So that can be started in the stabilizing phase, starting from the stabilizing phase. And then you have an increased catch-up growth, which goes on when in the transition and rehabilitation phases, where you give more energy to regain and get a catch-up growth. And also the sensory stimulation. I'll explain these one by one. So sensory stimulation is, as these children are children, so not only giving treatment, but also you have to stimulate them and make them happy even during the hospital. So that mental satisfaction or mental comfort is important for children to thrive as well. And also monitoring, of course, has to go on from the very beginning, from the stabilization, transition, as well as rehabilitation. One by one. So when the child is admitted first, the baseline investigations have to be done, biochemical, random blood sugar, because these children might be hypoglycemic. And when you start feeding, they might even have a risk of hyperglycemia. And also hemoglobin to detect anemia as well as infections. And also electrolytes, they are very important because they have severe derangements, which I will talk, especially in the focus of what is called a refeeding syndrome, which is pathognomic of low phosphate, potassium, and magnesium. So to detect this, you have to do serum electrolytes. It's important. And chest X-ray and urine testing, that is to see acute infections, and of course, liver functions and serum proteins. And also, this has to be always supported with a good clinical examination and monitoring of clinical parameters, such as temperature, which is very important. They have a high risk of hypothermia, which even can be the cause for their death if not treated. And also monitoring the vitals, such as the heart rate, respiratory rate, and capillary refill time, input, output, and level of consciousness is important in baseline investigations and monitoring. Then together, when you stabilize the child, then you have to start cautiously feeding, because we know their problem is malnutrition in the background. So why cautious feeding? So I would like to introduce this term, which is refeeding syndrome. So this is a range of metabolic and electrolyte alterations that can occur as a result of reintroducing calories to a person who had not had calories for a longer time. So when you're starving or when you don't have adequate nutrition, then your body is actually in a very baseline, the basal metabolic rate would be reduced, and the body adapts to manage the low nutrient coming into the system. And when you start feeding and you switch on to anabolism, here if you can see, so you start feeding, then you introduce carbohydrates. So carbohydrate will stimulate the secretion of insulin, and when insulin is secreted, potassium will be taken into the cells, and also the ATP, the pump which has been dormant, will start to work, and so the magnesium and phosphate requirements increases. So therefore, suddenly, if you have not replaced them or if you have not properly monitored, you will see that potassium, magnesium, and phosphate will drop in the child, and or even this can happen in an adult also. And because the metabolism starts working, it starts using thiamine which leads to thiamine deficiency. So therefore, this is characteristic of refeeding syndrome. So obviously with electrolyte derangements, absolute hypokalemia, and also there will be a relative hypernatremia. And then what happens is that they can even go into arrhythmias and life-threatening conditions. So therefore, a child who is tried to be therapeutically fed, that means you try to give a certain amount of calories, you decide what to give. In that case, this refeeding syndrome can occur. So that is why it's important to monitor the baseline electrolytes before you start feeding. And then also as you progress the feeds, you have to do daily electrolytes until the child is stabilized. So what are to give? What are you going to give in this as the initial feeds? So we talk about the starter formulas. These are commercial formulas. These are available in the world. So I have just put out these for you just to know that the existence of these things. We do not have these formulas in our country at the moment, but these are explained in the guidelines. So I have therefore put this, and I have to tell how we practically do in our settings as well. So the starter formula is a F75, we call it. So that is actually a reduced calorie formula. So that means it is less than 1 kilocalorie in 1 ml. So 100 ml has only 75 calories. So we consider this as a reduced calorie formula. So this kind of a formula is given because we don't want to give too much calorie density at the start. So F75 is the one that you start with, because high calorie densities, high osmolarities won't be tolerated by a malnourished child at the very beginning. So then moving on, when the child moves from the stabilizing phase and recovers little bit and stabilizes and there is no electrolyte derangements, in the transition you move on to F100, which is a more calorie dense formula, which is important for a catch-up growth. So we have to give increased calorie densities for catch-up growth, but that has to be done in a very staged manner, starting with a low calorie density and moving on to a higher calorie density as the child goes into rehabilitation phase. So, so what is the content? So these therapeutic formulas, the F75, in addition to the calories, proteins, the macromolecules, they have these electrolytes also, potassium, sodium, magnesium, zinc, copper, and all that. Also, the other elements. So therefore, when we feed, we have to particularly sometimes supplement these if the levels are deficient, if we don't use these kind of therapeutic formulas. So we don't have these. So in the absence, we actually can make these in our local settings as well. So we used to make F75 and F100 in our local hospitals, even at LRH, we used to make these. Now, of course, we have the therapeutic formulas coming into the country. So we use them also at the moment. But you can use these F75 formulas if you have just skimmed milk or whole milk and cereal flour, vegetable oil, and that is the milk is the protein source, and there's carbohydrate source there also. Cereal flour will provide the carbohydrate, and then you put sugar also as well as oil. So fat and carbohydrates, all you can make this into this composition, which gives 75 kilocalories in 100 ml or 100 kilocalories in 100 ml. So you can make this in the local settings also, and this was done previously before these new therapeutic formulas are commercial formulas are available in the local settings. So it's important that you combine the vitamin and mineral mix if you are preparing them in the local settings, because they are naturally not in those local ingredients. So then you will have to add this mineral mix. And if you don't have we usually don't have this even in our country. So what we would do is we would supplement the children with the standard vitamin supplementation when there are no specific deficiencies. And if we find specific deficiencies, we have to give therapeutic doses of vitamin supplementation. Otherwise, at least the RDAs, the recommended daily allowances have to be given when we start feeding these children with severe malnutrition. So how much to give in the stabilizing phase? So if there is edema, you give 100 ml per kg per day. And there is no edema, you can give up to 130 ml per kg per day. And 2 to 3 hourly, you feed the child and continue the feedings even at the night time. And sometimes they may need NG access. And if they are breastfeeding, you have to continue the breastfeeds as well. So breastfeeding child, you just continue the breastfeeds and you first give this formula and then top up them with the breastfeeds as well. So this is how the F100, similar to F75. By changing the ingredients, you can take the calorie density of F100, that is to give 100 kilocalories in 100 ml. Same ingredients, the sugar, oil, as well as the milk, as well as cereal flour. So you can make this the same calorie densities to make 100 kilocalories in 100 ml. This density is taken when you go to rehabilitation phase. So once the child is in the transition, so the now already vitals have been stabilized and you have started feeding cautiously with a relatively low calorie density feed like F75 or a local preparation similar to that. Or maybe diluted the polymeric formulas we have at the moment. So you can start the feeding cautiously with that and then move on to a higher energy density in the transition. And then we give what is called ready to eat, the ready to use therapeutic food or RUTF. These are solid food during the rehabilitation phase. So when the child is stable, you give the child the opportunity to eat by him or herself. So that is, you give RUTF. I hope you have seen this BP100 in your practice. So we have BP100 in our country and it is monitored by the Family Health Bureau. So Plumpy Nut, we used to have it. It is actually a peanut-based product, which was the reception was not very good in our population. So therefore, BP100 is what we use. So it's a high energy dense tablet. It's like a piece of alua, if I say, for anybody who has not seen it. So it has, in a one bar, it has 2 tablets. And 1 tablet has 150 kilocalories. So this has to be given with water or made it into a fine paste and given to smaller children. So this is the solid food variety that we give for children now entering stabilizing phase. So BP100 dose, so 150 to 185 kilocalories per kg per day. You can give calculated by the amount of calories in each tablet. So I told 1 tablet has 150 kilocalories. So then you can calculate the need of calories per a child according to the body weight, 150 kilocalories into the body weight per day. You can find the amount of calories you need. And when you divide it by 150, you will get the number of tablets you have to give for each child per day. So you can give that amount of calories until the anthropometric recovery. And also you can even reduce it if the child is improving, and then maybe you can reduce the quantity also to 100 to 130 kilocalories per kg later and until the recovery of the nutritional, reaching the anthropometric recovery. So you have to give it until they reach the mark of above the -3 SD levels. So monitoring during this process is the key to successful recovery. So as I told you, the most dangerous risks they have as they come is dehydration, infection, hypothermia, hypoglycemia, cardiac failure, and of course severe anemia also. So you have to monitor these throughout their stay in the hospital. So that includes so dehydration. So it's important that you identify in the clinically in the inboard care. So by looking at the cold peripheries, capillary refilling, and also the pulse volume and the other features of dehydration. And then and also treatment of dehydration whenever possible. You can rehydrate orally whenever possible. So if they are unconscious, you might have to use IV or NG feeds. So so the recommended the type of fluid if you are giving orally is what is called Rizomal. So that is for the rehydration solution for malnutrition. So this is a specified type of ORS, which is, I will show you in the next slide. The composition is slightly different from ORS, the oral rehydration solution. The new guideline says that in the absence of Rizomal, you can even use oral rehydration solution for this purpose as well. So if you look at the composition of the Rizomal versus ORS, so you would see that the glucose amount is higher because they have a risk of hypoglycemia, and sodium is of course lower because they have risk of relative hypernatremia, and potassium levels are high. As I said, they can get hypokalemia, and also they have extra chloride, magnesium, and zinc and copper in this special Rizomal solution. So that is the best, and that is what is recommended. But in the absence of it, we can still use ORS. And in some guidelines, they say that they will fortify it with more potassium because the requirement is high. But some in the WHO guideline, they even say they use in ORS alone for this purpose. So you have to provide every 30 minutes in the first 2 hours if you are giving orally 5 ml per kg per body weight, and alternative hours up to 10 hours, 5 to 10 milliliters per kg and of the Rizomal. And also you have to keep on feeding the child with F75 and you have to be aware of fluid overload also when you're rehydrating the child. So hypoglycemia, it can be even asymptomatic. And it can be asymptomatic. So that's why it's important to monitor the blood sugars. And it might come out with as lethargy, loss of consciousness, or even fits. So important to monitor these children on this and treat hypoglycemia if it is there. If it is less than -3 SD. If they are asymptomatic and they are conscious, you might be even able to use oral routes. Otherwise, you will have to use NG routes. And also, if they are again symptomatic, you will have to use IV 10% dextrose and followed by 50 ml 10% dextrose. And the feeding has to be continued F75 because it's the stabilizing phase that this happens a half an hour, and then every for the first hour you have to give every half an hourly feeds. And keep on monitoring the blood glucose levels until it is coming up to normal levels. If there is hypothermia, which is important, and this is something that we don't see in other conditions, but is very particularly for children who are malnourished. So they can get hypothermic, and that can be even their cause of death. So prevention is always to measure it, and also to keep the child warm is very important, because these children, as they admit because of their danger signs, they might be put to the high dependence units, which might be even AC'd or air conditioned. So in that setting, it's very important that you particularly look into this so that you keep the child warm. And it's important to have mothers skin-to-skin contact where possible and maintaining the temperature levels. And the next is important in preventing and treating infections. Mostly consider all children are infected, because when they come with severe signs, usually they have a superadded infection. So therefore, taking blood cultures and doing the basic investigations. And if the child has no feature of infections, you can start a broad spectrum oral antibiotic yet. And children with severe illness, then you might have to give IV antibiotics as well. Supplementation. So as I said, a regular vitamin supplementation has to be given if it is not fortified in the formula that you're giving. So usually BP 100 has all the vitamins. So then you don't want to give another vitamin for the child when they are on the full dose of BP 100. So vitamin A, if they have no features of deficiency, and we know we have a national program, and if they have not taken it recently, then we can give it age appropriately if they haven't taken their recent dose. And also, if they have severe deficiency features, then of course you have to give them the therapeutic doses of vitamin A, 50,000 international units for children less than 6 months, and for 6 to 12 months, 100,000, for more than 12 months, 200,000 on day 0, day 1, and between day 14 to day 28. So these have to be given if they have specific features of vitamin A deficiency. And also continue, as I said, the microvitamins as well as iron supplementation. So iron supplementation, we start only during rehabilitation phase, not during the stabilization or transition phases, because usually during this time, they have superadded infections. And so we do not want to promote infections with giving iron at that point. So iron supplementation is done during rehabilitation when the child is stable. And also, even if the child is not admitted to the hospital, outpatients, you can start on oral antibiotics such as amoxicillin as a prophylactic doses. So it's also important, as I say, to give stimulation and play and care even when they are very sick. So reading a book, reading stories, keeping them smiling, talking to them kindly. So all this matters for a child to thrive with severe acute malnutrition. So this has to be continued in ward settings and also should be promoted as the child goes home as well. Is important. And monitoring and record keeping has to be kept. And now we have specially NRP nutrition progress cards distributed by the Family Health Bureau for the management of severe acute malnourished children. So NRP cards, they have to be filled and maintained for each child so that the records will be there if they need in another admission. So when to discharge the child with severe acute malnutrition who is between 6 to 59 months? So it is not only one measure. It has to be a composite measure that you consider a lot of things together to decide whether the child is ready to discharge. So if they do not have danger signs for at least 24 to 48 hours, and also if they have the medical problems such as the pneumonia has settled by the time, and also if there is no ongoing weight loss and there is no the nutrition edema is resolving and there is no severe nutrition edema and they have good appetite, and then and also specifically this new guideline emphasizes that all attempts have been made to refer the children with medical problems needing mid or long-term follow-up care to be arranged before discharging the child. So when these factors all together come, so you can make a clinical judgment to discharge the child. So previously, we used to discharge the child depending on the weight gain. So this new guideline emphasizes that it's not about the specific numbers of weight gain, but actually the overall recovery of the child is important when we decide whether we are sending the patient out. And it's most importantly that whatever the problem that caused them to get the severe acute malnutrition has to be sorted by the time the child is discharged. So, so that means the follow-up care. So back to moving on to the child we were talking, Sarah. So this is where Sarah lives. So if you're going to discharge this child to the same environment as this, then you know this child will get recurrent admissions. So therefore, improving the sanitation of the house, teaching the mother how to stay in a better sanitation, and also referring them to local the facilities, local social support services if they have economic problems, like Sarah did. So it's important that you communicate them to whatever the local authorities, the agriculture officers, they are relevant in villages. So get the whole network, especially as general practitioners and people at the primary care. It's important to have that network that is the supportive service. Like there are mother support groups also in communities. So referring the mother to such groups and giving them the strength to come out from the environment that led to the child malnutrition is very important. So therefore, you have to actually look into these factors and plan the discharge from the day the child actually admitted, so that you have a good network and a good set of people to receive the patient once you set to the community. So on discharge, you give the ready-to-use therapeutic formula like BP100, a ration for 1 week, and then you have to keep monitoring the child. And then you can decide whether the child will exit, or you can discharge the child completely from the treatment protocols when they have reached to greater than -2 ST levels, and when their mid-upper arm circumference is also more than 12.5 centimeters or 125 millimeters. And also if they have no nutrition AD for at least 2 consecutive visits in your clinic or your MOH areas. So percentage weight gain and absolute weight gain should not be used as exist criteria, but it is the anthropometric gain, and also to see they reach beyond the -2 ST levels to completely discharge them from nutrition follow-up. So moving on to Sarah again. So she was successfully discharged to the community, and now she is active and improving. And on her review at MOH, or maybe even at your clinic, Mala, her mother, complains that Sarah does not like to take BP100 at every meal. Now, we have been giving her BP100 in every meal, and previously she was happy to take it, but now she is no more happy to take it for every meal. So then what are we going to do? So the child still needs a high calorie density diet to get out to move up to above -2 ST levels. So therefore, in this particular instances where the child does not want to take BP100, not because they don't have appetite, but because they are now bored with BP100 alone. So then at this point, what we do practically in our clinical settings is that we give them a high energy home cooked meal recipes for them to give as main meals, and then to convert BP100 as frequent snacks to fill in the calorie deficiencies. So that is something that we do in the clinics in our practical settings. This is it is in our local guidelines, but it is not mentioned in the WHO guidelines yet. But in our local guidelines, we do this. So if they don't like to take BP100, the full ration, which usually happens when they are recovering, then we plan high energy dense meals with their available food items, like the rice and the protein sources. So we give recipes for high energy dense meals, and then give BP100 to fill in whatever the gaps that is there in the calorie need. Right. So moving on to children managing of infants less than 6 months with poor growth and development. So this case scenario of Shihan, so this is Shihan, a 1.5-month-old baby boy who was brought to your clinic by his mother for routine assessment. His mother's concern is concerned about the growth and needs a solution. So she feels now she's breastfeeding and the child is not growing adequately. So you detect that Shihan is deviating from the birth trajectory right now and have seen poor growth. So in the background, Shihan was a term baby born with a good birth weight. His mother is Nisha, and she's a primary mother, and she lives with her maid, and her husband works abroad. So what are you going to do? So what are the criteria for hospital admissions? So are you going to admit Shihan to the hospital? So the criteria for admission of a child less than 6 months to hospital is if they have the danger signs, which I told before, for bigger children, and also if they have acute medical problems such as pneumonia or severe dehydration, diarrhea, or if they have nutritional edema, or if they so one of these things, or recent weight loss. So because they are very small, weight loss is important. So recent weight loss can be a consideration for hospital admission in this cohort. So, and these are the ones I told this to you before. So, and also not only those criteria, you have to, even if you don't have those danger signs, just as the bigger children, you have to again think twice, even if they do not have major problems acutely, but if they have HIV, tuberculosis, or if they have cardiac defects, such chronic problems, then you have to take individual decision whether to admit the child, even if they don't have the danger signs at the moment. And if they have specific anthropometric criteria, such as weight for length below -3 st and mid-upper arm circumference is less than 110 millimeters for infants between 6 weeks to 6 months, so that is very thin children, then you have to, even without danger signs, you have to consider whether you are going to admit, you have to decide it. You can do that in that case. And if there's also ineffective breastfeeding, feeding concerns, the mother is not competent, maternal related problems are also important in this cohort. So for Shahan, what we would do is that we would actually not need admission for Shahan. So so if they need to be admitted, if another child, we will see how we are going to manage. So since these children are breastfed below 6 months, you should always promote breastfeeding. So breastfeeding should be promoted at all costs, and also given support to the mother to breastfeed. And also, by providing the breast milk, there have to be supplementary feeding as well for these children. So if there is severe wasting and there's no edema, so with the breast milks, you can give either express breast milk as top-ups, or maybe things like commercial infant formulas, or F70, or diluted also can be given. And with children who have edema, you would give either commercial formulas or infant formulas or F75. This has to be given in addition to breast milk because they are severely malnourished. While giving breast milk, you have to give supplementary feeds of either express breast milk or other kind of milk. They are at a deficit of calories at that point. So wherever possible, you have to promote this suckling. Suckling that has to be given, like you try to mimic even the therapeutic formula. You have to mimic as if you are giving from the breast, so that you can quickly return them back to breastfeeding once they are stabilized from their acute malnutrition. So when to discharge them? So to discharge them, it's again a composite judgment. So if they do not have danger signs for at least 48 hours, and edema is resolving, and they are gaining good appetite, and then the weight gain is, they are gaining weight satisfactory, then you can try to discharge them in these children who are less than 6 months. And also here also you have to make sure that you have made the background for the child once you are discharged, when you are discharged, that is provided the mother with adequate help, and also referred to clinics where necessary for long-term follow-up if they have cardiac issues, renal issues, so on. So of course, even children who are less than 6 months old, you can treat them in the community. So that is if they don't have no danger signs and they have no other signs to think that they need in-depth management, then you can, even if they are less than 6 months, treat them in the community. So that is what we would plan for Shihan, to do it in a community. However, you have to follow up them properly, initially weekly visits, and then you can decrease the visits frequency depending on how the child thrives. So it's important to give the mother, especially in this less than 6 months group where they are exclusively breastfeeding, it's very important that you see whether the mother is capable and provide support to the mother to provide breast milk as much as possible. So for Shihan also, we would, the mother's techniques would be observed and reassessed and strengthened. And also we will teach her how to do express breastfeeding. So she's promoted breastfeeds and then on top of the breastfeeds with express breastfeeding. And we will also try to support from the bringing down Nisha's mother was arranged so that she was given social support to look after the baby. And frequent clinic visits have to be arranged in this case. So that brings to an end of the severe acute malnutrition. And I will quickly run through the management of moderate acute malnutrition also. So moderate acute malnutrition is when the weight for height is between -2 st and -3 st levels in the weight for height chart. So these children, they should have access to nutrition-dense diet to meet their full requirements. So they need nutrition-dense food. So adequate counseling and resolving any psychosocial issues is very important in this context also, even if they are moderately managed. And so for specially formulated food. So the specially formulated food are things like the Triposha program we have for children with moderate acute malnutrition. So in the new guidelines, they specifically mention the cohorts that we have to give these kind of specially formulated feeds. So they are the in the mid-upper arm circumference, that is when you check the mid-upper arm, the circumference, if it is between 1115 to 1190 millimeters, that is in the range towards the lower side. And also, if they are less than 2 years, and if they have done counseling previously and they are not responding, and they are repeatedly relapsing in moderate wasting, and they have a history also severe matron, and they also have comorbidities such as HIV, tuberculosis, and also mental disabilities, and social factors like if they are too poor or poor social support, then of course you can give these specially formulated feeds. In the Sri Lankan context, this is what that was what the guidelines said. So in Sri Lankan context, we have gone a step beyond. So we give supplementary feeding for all children with moderate acute malnutrition. So we have the Triposha program, which we are proud of, which has been now we lately had problems because of aflatoxin levels. But I will just give the overview of the basis of it. So it was defined to provide 350 to 500 kilocalories per day as extra take-home ration, and that will be given for children until they reach above the -2 st levels and maintain it up to consecutive 2 months duration. So that is what the Triposha program used to be, and we had hiccups of it because of aflatoxin levels, and now it is we are trying to restart it with a rice-based variety and also trying to restart it with better ingredients that are free from aflatoxin bad levels. So we are doing that in the way. So this is to tell you the basis of giving this supplementary feeds, because moderate acute malnutrition, they need energy dense feeds. So we as a country, we are giving for all children. But the previous slide, as I mentioned, there are criteria to give this where necessary. So enrollment criteria for supplementary feeding, according to the supplementary feeding, would be new admissions. Of course, if the child is between -2 st to -3 st, that is from the weight per height chart. And once they are discharged from the severe acute malnutrition, so if we have been giving them BP 100 and they have now come above -3 st, above the red zone, entering yellow zone, we can refer them to these specialized feeds such as Triposha. And also some of them can be readmissions and relapses, and sometimes some of them can be returning due to default from previous programs. And we can actually make these things at home also. So, so this is one recipe that we have. I hope I tell the name properly. So, Satumavu. I think this is from the northern part of our country. Thiri might be knowing better about this. So, this is a local recipe that we can make it at home with all the cereals: millet, red rice, nuts, corn, green gram, barley, sago. So, you can put whatever the cereals that you have in your household, properly washed, dried, milled, and then make them into a powder and then mixed to give a certain similar thing as Triposha. You can even make this in the local settings also. So that is about the moderate acute malnutrition. And again, to emphasize at the end why it is important to treat children with acute malnutrition is because of their long-term outcomes. So they have found that the mortality is higher in these children, and about 300,000 deaths per year among children younger than 5 years in developing countries. And it's the third leading cause of death in some of the other countries. So our country is better in this regard, but then they are more prone to infections in our settings because of malnutrition. So therefore, there are recurrent infections because of their malnutrition, which will reduce their capacity as an adult as they entered. And also delay nutrition recovery. So 21% of disability-adjusted life years for a young child than in normal children. So that is, so because of their malnutrition, they are more prone for disability, as well as their growth is hindered because of malnutrition. So therefore, malnutrition is very important, especially in children below 5 years, because it can cause them death, it can cause them recurrent infections, and it can cause them deprivation of their potentials as a human being in life. So in summary, malnutrition poses a significant short and long-term effects on optimum growth and development, especially in children below 5 years. And early detection and appropriate referral for treatment is essential. An integrated care plan should be formulated, and considering the well-being of the caregiver is essential. Mother and caregiver of the affected child should be considered as an interdependent care and looked after for better outcomes. And so it's important to say, especially in children's malnutrition, that people of excellence go the extra mile to do what is right. So therefore, whenever you find a child who is malnourished, I would take this opportunity for you to emphasize, because at primary care, that is the most important. Usually you all are the family physicians, so that you know the entire family, their backgrounds, their struggles, their challenges. So therefore, it is important that you address these also and properly refer them to supportive services also, so that you support them to improve as a family also, because most of the children are in poor environmental conditions. So thank you for patiently listening. And I would like to take any questions in the interest of time.
Thank you, madam, for that excellent presentation and giving us knowledge and guidance on management of acute, severe acute malnutrition and moderate acute malnutrition, as for a knowledge or for the GP's level. And now we will now move on to the question and answer session. If anyone has a question, please feel free to type in the chat box or unmute yourself. There's already there are two questions. First question is from Dr. Manoj Lianage. Madam, to prevent refeeding syndromes, the minimum target phosphate level and any way to introduce or replenish phosphates. Is the question, madam?
Yeah. So, can you hear me? Yes.
Yes, madam.
So phosphate levels. So the minimum target that depends. So usually depends on the age as well as. So for adult ranges and children, we have different ranges. So generally, we try to keep the phosphate levels above 1 millimole per deciliter. So we try to keep it above that. So if it is really low, below 0.3, then that we call as severe deficiency, 0.3 to 0.6 moderate, and more than 0.6 generally is mild deficiency. So at least we try to keep it above 1 millimole per deciliter, so that safe level. So at the moment we don't have for children. Children, what we use is the Joule solution, the Joule phosphate that is available in the pediatric care settings. LRH has it. I think you can make it also in the pharmacy. Some of the pharmacies, they do that. So that is the oral Joule solution we use. So we give 1 to 2 millimole per kg as replacement. Unfortunately, we don't have IV preparation at the moment in our country. So for severe deficiencies, we should actually give IV preparations if it is less than 0.3 millimoles. But we don't have that. So we try to compensate with the oral phosphate solution, which works very well. And we also have the sodium acid phosphate we use for bigger children, which is a 500 milligram tablet with 16 millimoles of phosphate in it. So that we use for bigger children. For smaller children, what we would use is the Joule phosphate. So the dose we would give is 1 to 2 millimole per kg per dose per day in divided doses, and we can adjust this according to the levels. So we have healthy levels. We try to keep it above 1 at least for safe levels. And of course, that's important that we do the baseline phosphate level. And if it is less, we prophylactically, we start giving with the Joule solution and then cautiously start the feeding. I hope I answered the question.
Thank you, madam. There's another question. What is a homemade high energy meal for child?
Yes. So high energy meal for child is now usually if we take the BP 100 that I spoke to you of. So that has 1 gram has 5 kilocalories. So that is very high energy dense. So if you take Triposha like one also, it also has about 4 kilocalories per 1 gram. So that's also high energy dense. So so we will call anything above 1 kilocalorie in 1 gram. We can roughly mention as high kilocalorie. So to do this, we have to know our calorie calculations. So even with the rice meals, we can do this. So if we, for an example, take a rice, let's say for a child who is about roughly, for example, now we can, out of the mind, we can say, so rice, if we can temper it. So if you take, the child takes half a cup, so you temper it with about 1 teaspoon of oil or butter, and then you put it like you make it like to a fried rice, so that it becomes energy dense. So even the things like Triposha, as I said, you can make it at home. So if you have a mixed cereal flour, and then you take 3 tablespoons of it, and then you add butter, milk into it, and also a bit of sugar, that will give you that calorie densities. So even by adding especially oil, we don't promote a lot of sugar because they get addicted to the sugar taste. But using oil wisely is important to increase calorie density, especially in children who are having malnutrition. So the homemade ones would be energy dense in them. Like a small quantity, but you put oil also into it, and then maybe you put egg into it, so that you increase the energy density in a small amount of feed. So that is how we do it.
There's another question, madam. What is the proportion of ingredients in sattu maavu? Is it same amount?
So sattu maavu is a local thing. So that is from usually from the Jaffna Peninsula. So that they don't have a specific amount. If you have, what you can take is you take that as the cereal base. So you take all of that. So even if you take Triposha, what they have is the corn, and they also have soya, and also they have milk, and the mineral vitamin mix, and they have oil in it. So those are the ingredients. So similarly, so you can take the grain mixture from the sattu maavu. So, and if you take just as the portion, if you take 3 tablespoons from it, and then you have to add the butter. So when we make triposha, we even without adding butter, they have milk inbuilt in it. But here we will have to put a full cream milk, the butter into it, so that you make it energy dense. So roughly, if you take 3 tablespoons, add about 1 teaspoon of butter into it, and also add some either your breast milk or fresh milk into it. Then you can make the same energy densities at home.
There is another question. How to increase phosphate content in children's diet for deficient children other than oral supplement?
Again, what is it?
How to increase phosphate content in children's diet for deficient children other than oral supplement?
Okay. I would like if he actually, I don't know what kind of a scenario they are talking about. I would like if he could talk, I could give a better answer if he tells me the real clinical scenario he wants the answer to. However, the phosphate rich items are animal items. So animal proteins as well as milk has high phosphate naturally. And also things like cocoa, chocolate, so cocoa especially has high phosphates. And also whole grains have high phosphates. So therefore, by giving these things, you can have high phosphate intake. But I can give a more objective answer if he can speak up and tell me the question actually.
Oh yeah, the question is from Dr. Harsha Vijay Singh. If you can ask on.
Speak up, Harsha.
Thank you, madam. I got the answer, madam.
All right. So yeah. So those are the phosphate-rich items. Even nuts also have high phosphate. So
I just wanted to know about in young children, 3 to 5 years, if we come to know whether he is phosphate deficient, how can we supplement with that? I got the answer, madam. Thank you.
Yes. Yeah. So animal sources, nuts and whole grains, milk, and chocolate. Those are the things that you have high phosphate.
Thank you.
Any more questions?
Yeah. If there are any other more questions, you may raise hand or type in the chat box. So if there are no further questions, we will conclude the question and answer session. Thank you, madam.
Yes.
Hello.
Yeah, if you have any questions, please direct it to Thiri, and I'm happy to write back to you through Thiri, no problem. If you have any, and I would advise you to read this, the WHO guideline for a better understanding, which is online, the 2023 guideline. It has everything that I told as well. So I request you to read that also. And if you have any questions, you're free to tell it to Thiri, and I'll respond to her.
Yes, if you have any questions, you can put in our group, so I can take that questions and get the answer from madam, and I can reply to the group again. Madam, thank you for answering all the questions in such details, and thanks for the comprehensive and very insightful presentation. Your explanations on the management of acute malnutrition in children are very extremely valuable for us. Thank you so much, madam, and it is very helpful in our daily clinical practice. And I would also like to thank all the participants for joining us in this meeting, for your engagement and for the contributing to today's discussion. A special thanks to CPD Committee of the College of General Practitioners of Sri Lanka for organizing this session, and to the Education, Training and Research Unit of the Ministry of Health for accrediting it with 1 CPD point. And we look forward to seeing you again in our future CME programs. Have a pleasant evening. Thank you, madam, and all once again. Thank you.
Thank you. Good night.
Good night, madam.
Good night, madam. Thank you, madam.